So, hello everyone. Welcome to today's live broadcast, Building Confidence in COVID-19 Vaccination, a toolbox of talks from leaders in the field. So I'm Linda Klavinskis from King's College London, and together with my colleagues Denise, Doolan and Margaret from the International Society of Vaccines, I'm excited to welcome you all to today's event. So immunisation is heralded as one of the most important achievements of public health. And without question, vaccines have saved millions of lives and increased life expectancy. However, despite robust scientific evidence showing vaccines to be effective and safe, doubts persist amongst some in our community. So in the last year, the development and rollout of vaccines to combat COVID-19 has been an incredible feat of innovation by the global scientific community. But vaccines can only work in ending the current COVID-19 pandemic and returning life to normal when they are administered to everyone, particularly those in high-risk groups. But unfortunately, rising numbers of people are refusing vaccination for themselves and for their children, fueled by misinformation and mistrust. And concerningly, survey data are showing that minority groups who have been hit the hardest by COVID-19 are amongst the least likely to take up the offer of a vaccine. So the reasons for vaccine uncertainty are complex and vary widely, from perceptions of safety to mistrust of government and public health bodies. The scientific and research communities, coupled with healthcare professionals, are in a prime position to restore trust and confidence. But we must first explore the root causes of vaccine hesitancy, addressing the psychology of decision-making and messaging, as well as strategies for boosting vaccine confidence by effective communication from healthcare workers on the front lines to at-risk and ethnic minority groups. And that is precisely what our incredible panel of speakers aim to do today. So this live program today is presented in partnership by the International Society for Vaccines and MJH Life Sciences, home of brands such as Medical Economics, Psychiatric Times and Pharmacy Times, just to name a few. The International Society for Vaccines has organised 4 of the leading international research conferences on COVID-19 vaccine development in the past year, and we are delighted to host this webinar today with MJH Life Sciences. So just a few notes before we begin. This webcast is designed to be interactive, and we encourage you to submit questions using the question and answer tool underneath the video player. We'll take the last 10 to 15 minutes of the programme to answer audience questions. The slides will advance automatically during the event, but if you are having problems viewing or hearing the webcast, please just click on the support icon to report your issue. So a little bit about myself. So I'm Professor of Viral Immunology at King's College London, and my research focuses on understanding the mechanisms by which the innate immune system regulates adaptive immunity and harnessing such mechanisms in the design of new and more effective vaccines. And within the vaccine community, I'm a fellow and secretary of the International Society for Vaccines. So joining me on behalf of the ISV are Professor Denise Doolan and Professor Margaret. So Denise Doolin is President-elect of the ISV and also a Fellow of the Society. She is a Professor of Molecular Immunology and Vaccinology at the Australian Institute of Tropical Health and Medicine, based at James Cook University in Australia. Her research focuses on understanding protective immunity to tropical diseases of global importance, such as malaria and tuberculosis, to inform rational vaccine design. And she'll introduce the panelists today. And then finally, Professor Margaret is chairman of the board and an ISV fellow. She pioneered DNA vaccines and works with a variety of organizations in global health. And additionally, she is adjunct professor at UCSF and at the Karolinska Institute as well. And is also a member of the WHO drafting group for recommendations for mRNA vaccines. And Dr. Liu will be moderating the question and answer session at the end of the program. So now I'll hand over to Denise Doolan.
So I would like to now welcome our panel. It is my great pleasure to firstly introduce Dr. Heidi Larson, Director of the Vaccine Confidence Project and Professor of Anthropology, Risk and Decision Science at the London School of Hygiene and Tropical Medicine. Dr. Larson previously headed Global Immunisation Communication at UNICEF, chaired Gavi's Advocacy Task Force and served on the WHO SAGE Working Group on Vaccine Hesitancy. She is a celebrated anthropologist, and her research focuses on the analysis of social and political factors that can affect uptake of health interventions and influence policies. Her particular interest is on risk and rumour management, particularly around vaccines and immunisations, where she is acknowledged as the world-leading expert on building public trust. Dr. Larson's talk is titled Vaccine Confidence in a Time of COVID-19. The next speaker will be Dr. Marie Brown, Director of Practice Redesign with the American Medical Association and Professor in the Department of Internal Medicine at Rush Medical College. Dr. Brown has practiced as an internist for over 30 years and is a past governor of the American College of Physicians. She is a leading policy expert on medical adherence, immunisation and related public health issues, and we look forward to hearing her insights into the front line on vaccine hesitancy. The title of Dr. Brown's talk is COVID-19 Vaccine Hesitancy, Effective Messaging for Patients and Healthcare Workers. The third speaker today is Dr. Wolfgang Gazzania, joining us from Germany, where he serves as a Professor of Social Psychology and Decision Sciences at the University of Konstanz. Dr. Gaissmaier's research investigates how people make decisions under uncertainty and how risks can be communicated more successfully to help people make better decisions, particularly in medicine. His work has been published in leading psychological and medical journals, and he has received numerous awards. Dr. Gazzmaier's talk is titled When Emotion Trumps Evidence, The Psychology of Vaccine Hesitancy and What We Can Do About It. And last but not least, we have Samantha Ortega, Vice President and Director of Racial Equity and Health Policy at Kaiser Family Foundation in the US. She holds a master's degree in health policy from the George Washington University, and her work focuses on the intersection of racism and discrimination, social and economic inequalities and health, and she is leading efforts to advance racial equality in health and healthcare. Her talk will be addressing this topic with the title Ensuring Racial Equity in COVID-19 Vaccine Distribution and Uptake. So I will now hand over to Dr. Larson to start today's presentation. Welcome, Dr. Larson.
Thank you. I'm Heidi Larson, and I hope you see the screen. As you mentioned, I'm a professor of anthropology at the London School of Hygiene and Tropical Medicine, and director of the Vaccine Confidence Project. I founded the Vaccine Confidence Project 11 years ago, seeing that there was a growing increase in the number of questions and concerns coming from the public about the vaccines, the products, but also increasingly we were seeing that that was very intertwined with public trust and confidence in the providers and in policymakers and in systems. And sometimes issues in other places in the confidence trust chain affected confidence in the vaccine itself. So I founded the project to start to get a sense of how big the scope and scale of the issues, because one of the big questions I got when I tried to raise attention to this growing issue was how big of a problem is this? Is this just fringe? Do we really need to be spending our time focusing on that, or just the positive communications? So we set out to measure it. We developed a vaccine confidence index, and we've been doing social, initially online news media monitoring, but increasingly social media monitoring around the world in over 100 languages, and also a lot of local on-the-ground qualitative research through a network of research collaborations around the world. A few months ago, we published in The Lancet a big paper on 149 countries with our Vaccine Confidence Index, looking at change over time between 2015 and 2018-19, and the Financial Times that was covering the publication created this map, which showed that there's quite a spectrum of confidence levels in vaccines, with the axes on confidence in the effectiveness and confidence in the safety. But Japan being the lowest, and India, Uganda being high. And why is that? Well, many times we see that overall low confidence in a vaccine in a country, if the confidence index is low, it's often related to a particular event that happened, an individual vaccine that knocks public trust down. And in the case of Japan, it was the HPV vaccine, where a number of young girls got quite concerned and started to have what were assessed as psychosomatic reactions, but were a mix of physical mobility, paraparalysis, and other issues that were persisting. And 8 years later, the government has still suspended their proactive recommendation of the vaccine, even though you can get it. That and some other concerns has undermined current confidence in COVID. So this background rates of confidence do affect the current COVID confidence environment. In the Lancet paper, we can see that there's been a landscape of, in the domain of vaccines are important. Actually, the dark blue is positive confidence, the dark red is negative. We can see that over the last 3 to 4 years, there's been quite a shift in a good way for more positive confidence around the importance of vaccines. And I would hope that in the COVID environment, that importance of vaccines has become even stronger. But when it comes to whether vaccines are effective, whether they work, and even more importantly, in safety, there's a much more fractured landscape in terms of public confidence. And some countries have their confidence in safety have improved, while others it's dropped. And one thing we identified in 2015 was that Europe was the most skeptical region in the world when it came to vaccines. And France in particular had the, not by a small amount, lowest confidence in vaccines in general. And this has been, we see a lot of consistency with background confidence and COVID vaccine confidence. One of the concerning trends between 2015, 2018, 19 is in North and West Africa, which are the Francophone, primarily Francophone Africa. And we see that language diaspora, language media, can bring with that information, misinformation, and public sentiment. So that's a worrying concern, particularly when it comes to the implications for COVID acceptance. But by looking at this kind of weather map of confidence, it helps us identify where more confidence building measures are needed. The two countries that dropped the most over that period of time were Indonesia and the Philippines, both of which had vaccine scares, public vaccine concerns. In Indonesia, it was around the measles rubella vaccine, which had been given for years. This was not a brand new vaccine like the COVID vaccine, but some of the Islamic leaders had decided that they felt that it was haram. It was not consistent with, it wasn't halal in the Islamic faith, and they said it was forbidden. That was eventually overturned, but during that time, there was a significant drop in the confidence. Well, the Indonesian government was very conscious of that background vaccine scare and vaccine concern. So when they introduced the COVID vaccine, they were one of the first in Asia. They introduced the Chinese vaccine. They went to the Islamic Council early they went first. Along with the scientific assessment, they said, we don't want to go through what we did before. We want to make sure that there's a public endorsement of this vaccine by the Islamic Council. So once the Muslim body declared the Chinese vaccine halal, religiously endorsed, they went forward. So this speaks to the importance of both the scientific, but also the cultural and what the public feelings and concerns are about. In the Philippines, it was a different issue that knocked the confidence down. This was a bit different because actually it was over what was a real reported risk with the Dengvaxia vaccine, that for people who had no previous exposure to dengue, there was a chance that they might get more severe dengue after the vaccine. That risk was reported 1 year after the introduction of the new vaccine. You're probably familiar with that. And that created a disproportionate political drama relative to the risk. Brazil, that had also introduced the vaccine, relabeled the vaccine, gave training for their healthcare workers, and they made sure that the vaccine was only given to people who had been previously exposed. While the Philippines, it became quite a significant political vengeance against the previous government that had introduced the vaccine, and that still has undermined and shaken public trust. And it, as a lot of the media and colleagues that I've worked with and collaborated with in the Philippines say that really it has left an anxiety in the public that needed extra additional confidence building. This is a global challenge. It's rapidly evolving. This is a map in a paper we did on the Japan HPV scare, around the HPV vaccine, and how through YouTube and social media, the photographs of some of these girls who were fainting or reacting traveled around the world, creating a knock-on effect of similar events in multiple countries. We have shifted because we've had these systems that we've built over the last decade to be listening to public conversations about vaccines, to be surveying populations, to be doing in-depth qualitative research. With these networks and systems we've set up, we started shifting to listen much more to what public sentiments and concerns were about COVID, both the vaccine, but we've also been listening around public confidence in other government control measures, because we find that if people are more compliant with other things like distancing, masking, and accepting of these measures, they are more likely to be accepting the vaccine. That this is about an overall trust relationship. Vaccines are clearly different, but they still are in this domain of compliancy with a trust in government. As you can see, like confidence in general, there are no two countries that are the same. From a high confidence in Ethiopia to DR Congo, where 27% of the population says they strongly disagree that they would take a COVID vaccine. That was in June, July. In December, we ran it again with 32 countries. And with the highly varied responses on dark red being definitely will not accept, dark blue definitely will. Lebanon, publics are not sure who to trust. And we see that on the right-hand side, above all other socioeconomic demographic factors, the strongest lever of positive willingness to take a COVID vaccine is people feeling like the government is handling the response well. So it's a really important lever. We also look quite subnationally on COVID intent to accept a vaccine. And we have seen in London, both in London and Manchester, the lowest confidence, and that's consistent with some of our background rates. As I mentioned, we're also listening to lockdown, mask wearing, isolation. In fact, the vaccine conversations, we have to put them in the context of what people are caring about otherwise. And actually, vaccines was really a smaller part of the conversation through most of last year, really until later in the year. Lockdown has been a more prevalent frustration and concern in the public and anxiety, I think, being worn down by it. But I think there's a new hope with the vaccines, and the sentiments are shifting. In 2018, I had written a piece. There was a lot of discussion about, are we ready for the next pandemic? And I was already seeing that this viral misinformation was a risk for the next pandemic, which indeed it's become. But I also think that we shouldn't only, I find there's almost too much focus on debunking misinformation and not enough, I think, on the trust building. We've also been doing these surveys in Africa, across Africa, and also there we see quite a spectrum of differences. Some of the issues in Africa are not dissimilar than here in the UK or in the US. Concerns that, in terms of the conspiracy side, and such as the 5G linking to COVID. But we also see that those who believe conspiracy theories are less likely to take a COVID vaccine, which is what you would expect, but you don't know till you ask. Some of the key concerns: I don't trust the COVID vaccine. I don't believe the virus exists. I'm concerned about safety. I don't feel I'm at risk, and I don't have enough information. These are the top 5 reasons across Africa. This could be the top 5 reasons in just about any other country in the world. So there are themes around the world, but they play out differently. Don't believe the virus exists. Well, that's not just in Nigeria, that's also in London. We've seen COVID as a hoax, and in the US and in different settings, strong resistance to the need for even lockdown and vaccines. What's driving these issues is we have to, where at face value they may look the same. These are both protests against lockdown, but in Manchester it was much more about libertarian anti-government control, whereas in India it was much more, you're taking away our livelihood, we're day laborers, we can't feed our families. It was much more of a survival driven. What was fascinating to me is how some of these rumors and themes keep recurring over years. They replay themselves out in different ways. I saw the cover of the Times. They broke a story about a Russian disinformation campaign trying to undermine the AstraZeneca Oxford vaccine, saying that the adenochimp virus is going to turn people into chimps. But it made me think back in the 1800s etchings of the vaccination monster, and there's a whole file of people turning into cows because the smallpox came from the cowpox. So there is this human-animal connection there that is something that for those who are anxious and distrusting and can imagine a different outcome. I get a lot of questions. These are my last couple of slides here. A lot of questions about, well, there's a lot of misinformation out there, a lot of conspiracy, but does it really affect what people their willingness to take a vaccine? So we did a control trial, 8,000 people, 4,000 in the US, 4,000 in the UK. We interviewed all of them about COVID in general, but also would they take a vaccine? And before, 54% in the UK would definitely accept, 41% in the US. And then we exposed 1,000 on each side to scientific positive information, 4,000 to the 5 most frequently circulating pieces of misinformation. And for those exposed to the misinformation, there was a 6.4% drop in public willingness to take a vaccine in the UK after seeing these pieces of misinformation. At 2.4% in the US, but these may not seem like big drops, but when your starting point is low, already below herd immunity levels, if it was 85%, a few points down would matter less. But for me, the misinformation concern is that we're already on a wobbly place, and it can be a tipping point phenomena. So we do need to pay attention to it and try to mitigate it. These were among the pieces of misinformation. They're all very frequently circulating. But what is striking here to me was that the science, we talk about these questioners as being anti-science, which many of them would absolutely argue that they're not. The piece of misinformation about that was the most science-looking, which was about the RNA vaccine, was the one that had the most impact on people's change. It could be straight out of a genomics textbook, but if you read the small print, there's calling for the risk of genetically modified humans. First it was GMO, and now it's GMH. But that science-looking information did have more impact. This is my book Stuck. I just published it, came out with Oxford Press a few months ago, looking a lot more deeply at some of the things I've mentioned. And this is our website where we have a lot of our data and information if anyone's interested. Thanks very much.
So thank you very much, Dr. Larson, for a great talk and for sharing your insights. Thank you for joining us this evening. So our next speaker is Dr. Marie Brown.
Hopefully you can see my slides.
Yes.
Thumbs up. Wonderful. Right. Thank you, Dr. Larson. That was fantastic. And I am truly honored to have been invited to speak with all of you today. Many of you are healthcare workers or physicians, and you couldn't be busier than you are right now. As I said, I'm an internist and geriatrician, and over the past 30 years have had the privilege of caring for patients and have made that journey myself of listening to why they were hesitant, initially being angry, not understanding why they wouldn't take my careful advice. But once I began to listen a little bit more carefully, I understood their perspective. And I think only when we understand their perspective can we effectively message what I think Dr. Larson so eloquently discussed and has researched. Let's see if so it's helpful for me to frame how huge an impact immunizations have had. And over the past 70 years, we have seen such a huge decline in the number of vaccine cases of vaccine preventable illnesses that many of our colleagues and our patients don't think these exist anymore. And I think that's one of the problems. But it's really right up there with safe drinking water. But if we don't address this, this mistrust could really endanger our ability to get past this incredible pandemic that most of us probably never thought we would live through. And it is frustrating often for many of us on the call today to even consider when you are already vaccinated or you're waiting anxiously to get that appointment to be vaccinated. We can get frustrated, we can roll our eyes, we can shrug our shoulders and hope that science will prevail. But as Dr. Larson highlighted, that is not the case. But the good news, and we'll hear from another panelist later on today from the Kaiser Family Foundation, that most of you on the call are the most trusted source of information. People may not trust the health system in general or the government in general, but they trust you. You may have gotten them through a very difficult time in their life, and they definitely trust you. So we need to take advantage of that and be sure that we make, make sure that we are credible, knowledgeable, and respect that trust and provide the right information so that we can encourage all of our patients to take the vaccine. But it's not hard to think back to history, as Dr. Larson did, but only in 2008. This is a map of where measles cases, the larger the circle, the larger number of cases. And it was only 8 years later that because of mistrust, measles spread further across the planet. And this is a horrific disease. The number of people, children who die and are harmed forever, most people don't know. And one of the messages that seems to be effective for patients is to share that for many of these, there are no real good treatments. So people think, oh, if I get sick, my child gets sick, I'll just get treated. Well, no, for many vaccine preventable diseases, there is no treatment. And that's a surprise to them, and that can often push them to consider taking the vaccine. In addition, over 10 years ago in the BBC, we have heard from Dr. Larson, but also the effect of local religious leaders on our efforts to rid the planet of polio. Many years ago, religious leaders told the mothers that the polio vaccine was laced with estrogen and would cause sterility in their male children. I thought this was unusual, but then I had an opportunity to interview, and you can see this interview with a link at the end of my talk. One of my own patients here in Chicago, Illinois, when I asked her why she wouldn't take the vaccine, she said that she had heard in her community that it could cause sterility in the Black population and annihilate or get rid of the Black population. So with the social media and the internet, these stories circle very, very quickly around the planet, and we need to be aware of that. Again, from the Kaiser Family Foundation, we need to know who these groups are that are vaccine hesitant so that you can tailor your message. Sadly, in the United States, it is also quite partisan. But the real striking number here is that 30%, almost 30% of our healthcare workers would probably not or definitely not get the vaccine. And this is critical. So if your team, if you're a physician or an advanced practice provider, make sure that your receptionists, your medical assistants, your nurses, everyone who is patient-facing is knowledgeable as well. And I found that many of the team members that have not had the benefit of going to medical school or nursing school have concerns similar to those in the community and similar to your patients, but they're embarrassed or hesitant to share them with you because they know how strongly you feel about the benefits of vaccine. So asking them what they have heard in their community is helpful. And you may hear some things that they are actually thinking, but couched in, well, I've heard in my community that it could cause hair loss or whatever. And then addressing that concern will allow at least it to be surfaced, because often it's the medical assistant who is bringing the patient from the exam room from the waiting room into the clinic. And if the patient says, if the medical assistant says, well, you're due for this vaccine today, and the patient says, well, did you get yours? And if your medical assistant or your nurse says, yes, but I had to, that is not the response you want to hear. We need to get them on board, because if they are not very clear, they are credible, they are trusted by our patients, but they also need to be knowledgeable and convey their willingness to take the vaccine. You want to be sure that they will say, oh, absolutely, and then perhaps share a short story about somebody who didn't, or why they took it themselves, because that is very powerful for our patients. Dr. Larson highlighted some of the conspiracy theories. I'm going to highlight just a few. Again, it has been anti-vaccination groups have been around since the smallpox days. And in fact, the term conscientious objector came from moral disagreement with taking the vaccine. We need to be aware of and own the misinformation in modern day. I will briefly talk about Andrew Wakefield. This was as well as talk a little bit about some conspiracy theories. Andrew Wakefield, a gastroenterologist in the UK, published this article based on the experience of 12 children only. And this caused this storm of an association, was proved to be completely false between vaccination and developmental disorder. And when I first saw this many years ago, I thought, oh, my poor pediatricians. I, as an internist, thought, oh, I wouldn't need to have to address this. But as Greg Poland said, this cast a fog of suspicion on all vaccines. So whether you're in the front line, whether you're a primary care provider, whether you're an anesthesiologist, a radiologist, and a surgeon, we all need to know some of this basic information and be very clear that there is absolutely no link between vaccines and autism. And if you're not familiar with the information, I refer often to immunize.org, and everybody on your team needs to be aware as well and be very clear and credible because they trust you. And none of us can hope that our colleagues will bear this burden. It is for all of us to address. Some of the conspiracy theories that I'm going to mention are Dr. Larson touched on, but they have a lot of impact. Here, the Pew Research Center just last year reported that a large number of citizens of the United States have heard about the conspiracy that COVID-19 was planned. And sadly, a third of them say it is probably or definitely true, which is hard to imagine. But again, remember that physicians, healthcare providers are very much the trusted resource. And Andrew Wakefield, though he lost his license and cannot no longer practice, and his article was retracted and proven false, and his reporting was dishonest, he was a physician. And we're faced also with a current physician also sharing with nearly 500,000 Facebook followers that this was a plandemic. So the power of the social media can really not be underestimated here. Another conspiracy theory that has spread and caused over 100 episodes of cell towers in the UK to be vandalized. This conspiracy goes that it is strategy by global elites, such as Bill Gates, to roll out vaccines with tracking chips that would be, again, activated. And this is widely spread, and people are hearing this. And the more one hears things, this is the psychology of the more often one hears, whether it's true or not, the more familiar it becomes and the more likely it is to be believed. So I'm going to talk a little bit more about the effect of social media. This is a study from The Lancet last fall. And since 2019, there are more than an increase of 7 million social media accounts. 31 million people follow it on Facebook. But this is big business. These social media firms will receive over $1 billion in annual revenues. The World Health Organization has warned that this is an infodemic of false information. And I'll share with you and encourage you to look further into a very elegant study published in Nature, looking at, of the 3 billion, looking at 100 million Facebook pages that expressed any view about vaccination. And we can see how this distrust really evolved. And I'll show you a graphic that's in this paper. But the bottom line is that the anti-vaccination Facebook pages clusters, and these are Facebook pages with likes, are much more effective and very highly entangled with the undecided. So this is from that paper. Here you can see that each dot is a Facebook page with likes. The red dots are about 4 million anti-vaccination sites or pages. The blue are pro-vaccine. And they have the blue is almost twice as many, 7 million. However, they're not as effective as the anti-vaccine groups as being centrally located and touching by linking and liking with the 75 million undecided. So as you can see, the blue dots think that they're the pro-vaccine are effectively communicating with some undecided and may have a false sense of security that they are being effective, when in fact, if you look at around the world and follow these links, the red dots, the anti-vaccine group, even though half the size, may have twice the influence. So they reside in a more central position, and they are dominating really the undecided person. And what's interesting in this paper was these undecided folks are not passive. They are sharing those links with other people, many of whom are undecided. So these authors' theoretical framework reproduces this explosive growth and predicts that these views will dominate within the next 10 years. And again, this was based on data from 2019. So I would imagine it's less than a decade that we are going to see that most undecided, people who want to do the right thing, they're confused about all the information they hear, but we may be losing the battle there. And it's certainly an opportunity for us to pay attention to this and see what we can do to counter it. Let's step back a little bit and also, before social media, understand patients' perspectives. And here in the United States, many of you have heard of the Tuskegee study. I will briefly share this because in the African American community, this is well known, and people, it is the basis for a tremendous amount of distrust. And if we as clinicians don't understand it, we won't respect that distrust and work harder to earn their trust. So this is a study that began in 1932, long before there was penicillin available. These were farmers in the southern part of the United States. This was funded by the US government to look at the natural history of syphilis. In 1945, penicillin became the standard of care. And at this point, the farmers who had syphilis were not offered treatment. And in fact, when they sought treatment, the government reached out to the doctors and told them they would ruin the study if they provided treatment. Sadly, horrifically, this did not end. This study did not end until 1972. So people, these farmers, were watched for 30 years after penicillin was available and could have been treated. So we really need to understand what has happened in our own country so that we can address it. And I won't go into this. Dr. Larson did a great job talking about halal, similarly addressing and going to religious leaders early to make sure that concerns were addressed there is key. And I'll spend the last few minutes talking mainly about solutions. And the bottom line is we have to show that we care, and we have to be knowledgeable. Even though we're not giving perhaps the front line, giving the vaccine, we are a trusted source of information. And again, you saw this, and you'll probably see it again. You are the most trusted source of information. This slide really helps me understand how important it is and how difficult it really may be to develop trust. You may be the most brilliant virologist, infectious disease, pediatrician, internist, nurse, PA, and you have tremendous competence. You will be respected only if you also don't show and have the time to show you that you care. You may love your patients may love you, but if you don't understand and know have the knowledge about vaccines, they'll have great affection for you, but only when you show high caring as well as a tremendous amount of competence and knowledge, will they trust you? So you have a tremendous amount of input. We all want to wear our COVID vaccine button when you get it. I'm encouraging everyone to do that because you are trusted and what you do really matters. So the credible sources. We also will hear that the public views statistics very differently. And we know that from the lottery. People put money down thinking that they might win when the chances of winning the lottery are 1 in almost 200 million. So sharing that an adverse event could occur in 1 in 200 million, that doesn't mean, it doesn't have the impact that it would to us scientists. And it's very important that you be sure that you give that message, whether you're an orthopod, a dentist, seeing patients frontline or not. If you don't say you need the vaccine, not saying anything is saying something. So it's very important that we all share with our colleagues the importance of it. So for the hesitant patient, they're busy, they don't know what to believe, they're hit with all sorts of information from many various resources, then they're confused. To counter most of them, we can develop programs, look at mandating for schools and such, or for workplaces, especially hospitals, and we'll make it more difficult to opt out than to opt in. This is an example of the numerous, the green is 3 types of medical exemptions in the United States that are permitted in school depending on the state. We really want to target those patients who are sitting on the fence, not the extreme anti-vaxxers. We're probably never going to change their minds, but that 75 million that you saw on the social media page, those are the people we want to provide information to. And a story beats epidemiology every time. However, we're taught in medical school not to rely on the last story that we or the last case that we were influenced by, only rely on the numbers. So it's a different way of thinking, and telling stories is what we need to do to, and again, it's easier to scare people than to unscare them. So we want to vaccinate them against being scared first. And again, we want to be sure we know and tailor our message. If you know your population is more rural or urban, whatever minority group, age group, tailor that message. And this, again, from the Kaiser Family Foundation, if half of the patients believe that taking the COVID vaccine is a personal choice, but your message to every single one of those patients is it's everybody else's responsibility, and you believe in herd immunity, then you're going to miss the opportunity to communicate effectively to half your population. And what does work, as you can see on the 3rd line down, all groups worry about getting somebody in the family sick. So finding out who's at home, it's an elderly parent, that is the way to communicate that. Lastly, just last week, the U.S. Bishops Conference here in the United States spoke out against receiving some of the COVID vaccines. However, we know that Pope Francis recommended that it was a moral obligation, and fortunately posted in Vatican News that he and Pope Benedict did receive the vaccine. So if you have a Catholic population, knowing that the Pope came out in strong support of the vaccine is very important. We want to be very clear that you cannot get COVID from the vaccine, and we want to say it very, very definitively. That's why people don't take the take the flu vaccine in the past. And these are some of the scripts that you can use. I told my staff to tell people that this will, when they give them the influenza vaccine, tell the patients this will not prevent the common cold, because they get a cold 2 weeks later, they think it was the flu vaccine. This script is to respond to people who say these diseases don't exist anymore. People who want to use natural immunity. You can talk about having a fire extinguisher in your home just in case. And lastly, if everybody else gets immunized, then I won't need to. And here's a script to counter that effect as well. And again, speaking about who's at home may be more powerful. I've published some of these opportunities to talk with patients in this article. And many of the interviews that I did with my patients are posted open access and free on a site at the AMA called stepsforward.org. So I'll end there with some more sites, and I know that these will be shared with you. And the take-home points are that most patients want to do the right thing. They trust you. And we really need to counter the misinformation, effectively use social media, because only then will we be able to beat this virus and put this pandemic hopefully behind us. So thank you, and I'll hand it over to
So thank you very much, Dr. Brown, for a wonderful talk and for sharing your experiences of the different vaccine hesitant groups and also the effect of social media in amplifying misinformation. So let me hand over now to our next speaker, Dr. Wolfgang Gaissmaier. Wolfgang, welcome.
Yes, thank you so much, Linda. It is really a pleasure and an honor to be among this crowd and talk to you about the emotion and psychology of vaccine hesitancy. And so I'm not a physician. I'm actually a decision scientist at the University of Konstanz into basic research on how people make decisions and how we can help them make better decisions. And I'd like to share those insights with you. But before that, of course, I'd like to disclose my conflict of interest. I give such talks, also receiving honoraria from the pharmaceutical industry. What you've heard already in the previous talks is that vaccine hesitancy is actually a widespread phenomenon. And what strikes me as particularly worrisome and surprising also to some degree is that it is particularly a problem among the well-educated and the wealthy. Yeah. So here you see data from the Wellcome Trust, which is similar to other data you've seen earlier, that plots how many people believe or don't believe that vaccines are safe or that it's not effective. And what you see is that actually, even among many Central European countries, or especially there, actually, you find large proportions of people who, for instance, disagree that vaccines are safe. And we've heard earlier that France is a particularly worrying case. And then if you look how the income level of the country interacts with believing in science, then you see more patterns that are, I think, intriguing. And of course, people who believe less in science are less likely to believe that vaccines are safe. But this effect is actually, or this relation, it's a correlation, of course, only, is particularly strong among the high-income countries. And even within countries, you often find that anti-vaxxers, or those who doubt vaccines at least, are often the well-educated and wealthy. So those who are otherwise well off. And this, I think, is something that is really worrying to me. So what are the obstacles that we observe? Well, vaccination is rational, so from a decision scientific perspective, if the risk of the disease is larger than the risk of the vaccination, which is clearly the case in all of the vaccines that we've heard of today and all the vaccines that are recommended. And we do face some obstacles with this. Firstly, we have a misperception of risk that is extremely well documented. Secondly, we know that medical information, so if we like to educate people, it is often difficult to understand. And that is not only true for lay people, it is even true for medical experts, actually. Thirdly, it's not only about not being able to understand the numbers. There is also something that I call a lack of evidence culture. People often don't like to base their beliefs on scientific evidence, and they harbor many illusory beliefs. That is a problem. And fourth, you have social influence and polarization in the internet era, and you've already heard about that, and I will show you a little bit more on those grounds. So let's start with the misperception of risks. It's extremely well documented in psychology and the decision sciences more generally that people often fear the wrong things. Yeah? They are worried about genetically modified food, but they're not worried about a sedentary lifestyle, although the latter is probably way more dangerous. They are worried very strongly about flying, but not about driving, although, of course, driving is much more dangerous than flying. Yeah? So this is the case in many areas, actually. Many diseases are less common now thanks to vaccination. We've already heard that vaccination is probably, together with clean water and probably antibiotics, these are the big breakthroughs in medicine. So these are much less of a threat now, these diseases, and they're not visible anymore. But that also makes them less of a perceived risk to people. So I hear often people say, yeah, but why should I take the measles vaccine? There are almost no cases of measles in Germany. Yes, and that's due to the vaccination. So it's the paradox that we observe here. We know the omission bias, that people are less afraid of the risk of inaction, so letting nature take its course. Yeah, that feels less risky than doing something, getting the vaccine. If you give someone a shot, then you feel responsible for the side effects. If you don't do anything, you don't feel as much responsibility if that person gets sick because nature kind of took its course. Of course, we know this is wrong. You should always weigh the benefits and harms of both actions to make the decision. And finally, we know that vaccination is also a social dilemma. If all others are vaccinated, it may actually be individually rational, so from a pure homo economicus standpoint, not to be vaccinated. And this, of course, undermines herd immunity, so it's a real social dilemma. So, of course, it is better if all of us just get the shot. So this is the misperception of risk. Then if we try to communicate evidence, we know that evidence, clinical evidence, is often difficult to understand. And we've seen many Lancet articles today. I probably have the oldest with me here from 1937. This is one I love. It's entitled Mathematics and Medicine. And it says that statistics are curious things. They afford one of the few examples in which the use or abuse of mathematical methods tends to induce a strong emotional reaction in non-mathematical minds. And this is because statisticians apply to problems in which we are interested in a technique which we do not understand. And to frustrate you a little bit, this article is not meant to describe the state of the art in the general population, but in physicians, actually, and then complains how bad the statistical education in medicine is. And I think it has improved in the last decades, but I think there's still room for further improvement. So understanding statistics is difficult for many people. But even if people actually understand statistics, they often don't want to hear them and rather spread illusory beliefs. And here we have a famous example from a former president, this was before he was president, about the autism MMR connection that we've heard about earlier today, which caused so much harm. It's unbelievable. Huh? And he presents an individual case. Healthy young child goes to doctor, gets pumped with massive shots of many vaccines, doesn't feel good, and changes. Autism, many such cases. Yeah? And of course, we know you always need to look at the counterfactual. There will be coincidences that a child gets vaccinated and gets diagnosed with autism shortly after. Yeah, and of course, you need to look at the control group. So you need to compare those to make an educated decision about whether these two are related, and they are actually not. But people are extremely ready to base their beliefs on such singular stories of these kinds of coincidences. And that is a big problem. And this example already hints at social influence. So people don't only harbor these illusory beliefs, they spread them in social networks. And you've heard about the Japan case also earlier before. So this is the HPV vaccine in Japan. This is data from Sapporo, and you see a sudden drop in vaccine uptake rates. Yeah? What has happened? Well, there have been unconfirmed media reports about adverse events. I think there were 2 cases where it was unconfirmed whether they had anything to do with the vaccine or not. But these spread virally in the media, and then also in the social media. And what happened subsequently was that the Japanese Ministry of Health, Labor and Welfare suspended their proactive recommendation in favor of the vaccine. They didn't recommend against it, but it was obviously enough that they didn't proactively recommend it anymore, and the uptake went down heavily. Yeah? So there you can see what kind of large effects a few media reports that spread in the social media and the regular media can actually have. We were interested in our laboratory to study how messages evolve in social networks. So we set up an experiment that looked like this piece of art. It was a telephone game where the first person was given some information about some everyday life risk. It was a chemical substance and that is present in many everyday products. And this first person was then asked to talk about this risk with a second person. The second person talked to a third person, and so forth. And we stopped these diffusion chains, as we call them, after about 10 people. What happened to the information? We could systematically analyze what happened to this and how the message evolved. Well, what we saw, of course, is that information died out very quickly. The amount of information that was passed on decreased substantially over time. But what we also saw was that, and here you basically see relative survival rates of different pieces of information. What you can see is that the red kind of information, this is the alarming information, it died out to a lesser degree, so it was more likely to survive than the alleviating information that you can see in blue. So over time, the messages got substantially more alarming. Yeah? So in the beginning, it was mice who had in these studies had some trouble with the chemical, and at the end of the chain, it was people who died from it. Yeah? So it became much more alarming. And what we also saw in that, and in many other studies actually, is not only our research, many people have shown this, that people trust information more if it fits to their prior attitudes. So they like to hear the science they already believe, but not if it challenges their beliefs. They interpret information in a way that supports their prior attitude. So you give the identical piece of information to 2 different people with different beliefs, and both feel confirmed in their belief if it's a balanced article. Yeah? So this is extremely challenging. People select to communicate those pieces of information that fit to their prior attitude. So if it's in a social network, every party passes on information that fits to their beliefs, and then you have this polarization between groups that is actually evolves extremely rapidly. And finally, people frame identical pieces of information differently to make them fit to their prior attitude. So someone who's alarmed will also choose an alarming frame. Someone who's not alarmed will choose a less alarming frame. And this is not only true in health, but also for other topics such as climate change. So, what can we actually do? Yeah, so all of this sounds very depressing, but yeah, I think there is much to be done. Also, I know that probably many individual physicians and healthcare professionals are here today, and they wonder, yeah, this is all nice and good, but what can we do? How can we talk to our patients? So what I think what would help is if we started communicating the benefits and harms of vaccines understandably. And here you see a facts box on the HPV vaccination, just as an example, how the data can be summarized in a way. So this is data from the Cochrane review, how this data can be summarized to be easily understandable, even to normal people. Yeah? And it also helps physicians actually understand the information. Yeah? And we know that information and knowledge does not change attitudes very much. So this will probably not help you to change somebody's opinions, but it will also help you to create trust, to show that we have nothing to hide. There's often conspiracy theories out there that we hide all the relevant data. No, we have nothing to hide. The evidence for vaccination is overwhelming. We can just show the data to people. But we shouldn't stop there. We should complement this clinical evidence with good stories. That's also, we've had that previously. And these good stories should highlight the risk of the disease rather than the probabilities. As you've probably seen, I'm in love with probabilities, but I know that not many other human animals share that love with me, to my great disappointment. But we are a narrative species, not a statistical species in that regard. So share good stories. Understand the reasons for vaccine hesitancy and target clients. We also have that. Target clients who have barriers or safety concerns rather than the anti-vaxxers. Don't waste your time on the orthodox anti-vaxxers. This is like a religion. You won't change their beliefs. But there's a larger group of the undecided, of the fence sitters, and those you can actually talk to, and you can have an impact on those. So understand what their concern is and target it specifically. You should set positive messages rather than repeating myths when you try to correct them, because this can actually backfire. Of course, if somebody comes to you and presents you with a myth, such as the MMR-autism relation, you need to debunk it. But don't debunk it proactively, because then you will repeat the myth. And if people try to memorize or think about your conversation like a week or two later, they will probably not know exactly what you said, but they will remember, there was this debate about the MMR-autism relation. They won't remember exactly. So this is dangerous. So don't repeat it, rather set positive messages when you talk to patients. What is also extremely important, and that can actually get people who are very skeptical about vaccines, that can get them on board. If you highlight the social benefit for others, especially those who cannot be vaccinated and don't have a choice about, like newborns, and show them the phenomenon of herd immunity. If only some get vaccinated, the virus spreads. If most people get vaccinated, then actually spreading is contained. So don't target the individual benefit only. Don't target selfishness so much, but please target the social responsibility that we have. And finally, make getting vaccinated the default option and lower barriers. So it should be made easier to get vaccinated. And at the moment, it's very hard to get a COVID vaccine, actually. I will probably be due in August or September if I'm lucky. And you should already in your communication make clear that it is the default to get vaccinated. Here's an observational study that analyzed how providers initiated the conversation about the vaccine, whether it was presumptive or participatory. And I'm usually a big fan of participatory conversations, but here a little bit of presumptiveness helps, actually. And this is the slight difference between telling to the parent, well, the vaccination of your child is due today, versus asking them, what do you actually think about vaccinating your child? That's very subtle, but this observational study, it made a big difference on the acceptance rate of vaccination. So how you talk to your patients can make a big difference. And with that, I thank you very much for your attention and pass on to the next speaker. Thank you.
So thank you, Dr. Gaissmaier, so much for a really terrific talk and for giving some real good pointers on how we can build vaccine confidence. So now let's move on to our final speaker of the day, and that's Dr. Samantha Ortega. Welcome, Samantha.
Thanks so much for having me. I really appreciate the opportunity to be included in today's discussion. I know we want to leave some time for Q&A, so I'm going to try and launch right in to my talk. Before I get into the details, I do just want to provide a little bit of background about my organization, Kaiser Family Foundation, otherwise known as KFF. If you're not familiar with us, we are a nonprofit, nonpartisan organization that seeks to provide timely and reliable data information and analysis to help inform national health issues within the United States. Our work includes data and policy analysis, polling and survey research, journalism, as well as public health information campaigns. And you're going to be seeing elements from each of those aspects of our work in my presentation today. I also just wanted to clarify, particularly for those who are in the U.S., that we're not affiliated with Kaiser Permanente Health Plan or Health Foundation in any way. Before we dive into really focusing on equity in COVID-19 vaccination efforts, I think it is really important to step back and really recognize that the pandemic has not had equal effects across groups. We know that people of color have experienced significantly higher rates of illness and death due to the pandemic. On the slide here, which is based on national data from the Centers for Disease Control and Prevention here in the US, you see, for example, that American Indian and Alaska Native, Black, and Hispanic people have been 3 times as likely to be hospitalized due to COVID-19 and roughly twice as likely to die from the disease. We also know from other research that the pandemic has taken a much harder toll financially on some groups versus others. So these disproportionate impacts of the pandemic have resulted from underlying inequities that were, that were in place long before the pandemic. Those underlying inequities put people of color at higher risk for exposure to the pandemic due to their work, living, and transportation situations. It also put them at higher risk for serious illness due to higher rates of underlying chronic disease. And people of color have faced greater barriers to accessing testing and treatment due to higher uninsured rates and more limited access to care. So even before the vaccines became available, there were concerns that these same underlying structural inequities would similarly contribute to disparities in vaccinations that would lead to people of color being left out or left behind in vaccination efforts. And the early vaccination data are beginning to bear out those concerns, particularly for Hispanic and Black people who so far have been roughly half as likely to be vaccinated compared to white people based on federal data. And we see similar patterns when we look at state-reported data that looks at vaccinations by race and ethnicity. Notably, as you can see here, vaccination rates have been higher among Indigenous populations, and this may in part reflect more complete race ethnicity data being available for these populations, but we're more and more hearing experiences that suggest it also is reflective of the primary role that tribes have played in leading and implementing vaccination efforts among their own communities. And I'll talk a little bit more about why that would make such a difference in what we're seeing in terms of vaccination rates. So the gaps in vaccinations we are seeing for Black and Hispanic people likely reflect a variety of factors. I know that today we are really focused on vaccine hesitancy and attitudes, but I think it's really important to highlight that I think a lot of what we're seeing in terms of these early patterns of disparities is reflective of access barriers that are disproportionately affecting people of color, particularly during this early stage of the vaccine rollout process, where here in the US, vaccine access among eligible people in many areas is really happening on a first come, first served basis. And getting an appointment is often dependent on having resources like high-speed internet, transportation, and flexible work schedules. So I think what we are seeing is that access barriers are likely driving many of these gaps we're seeing in vaccinations. Currently, many of the sign-up processes leave barriers in place for people who don't have access to high-speed internet or devices to sign up through online systems, who have limited transportation, and who have limited flexibility in their work and caregiving schedules. Other barriers that are access related may include lack of information about how to access the vaccine, linguistic barriers, challenges providing documentation that might be requested, such as personal identification or proof of falling into an eligibility category, Moreover, the higher uninsured rates among people of color mean that they are less likely to have an established relationship with a provider, and they may have more concerns about out-of-pocket costs if it has not been made clear that the vaccine is available for free. Lastly, people living in immigrant families here in the U.S. may have concerns about their eligibility for the vaccine and potentially fears about accessing the vaccine. So I know Dr. Brown highlighted some of the work that has been coming out of our Vaccine Monitor Survey project, which is an ongoing survey we conduct here at KFF to assess people's attitudes and experiences getting vaccinated. And it's based on a nationally representative sample of adults in the US. And we see some of these same barriers reflected in these data. Here you can see that over 2/3 of Black and Hispanic adults say they don't have enough information about when people like them will be able to get the vaccine, and nearly 2 in 3 say they don't have enough information about where they would get one. Beyond access barriers, people have questions and concerns about the vaccine that influence their willingness to get vaccinated. For example, here we see that Black and Hispanic adults are more likely than white adults to want to wait and see how the vaccine is working for others before they feel comfortable getting it themselves. Although that share has been declining over time, while the shares who say they've already gotten it or want to get it as soon as possible have been increasing. But we know that across groups, adults who fall in that wait and see category have a range of different concerns about the vaccine. Black and Hispanic adults are particularly concerned about potential side effects, that they might get COVID-19 from the vaccine itself, but also other factors like that they might have to miss work if they have side effects, that they might have to pay for the vaccine, or that they won't be able to get the vaccine from a place that they trust. So in addition to addressing the access barriers that I've outlined, addressing these questions and concerns is also going to be a really important part of efforts. Healthcare providers, as you heard, are really a top trusted source for information on COVID-19 vaccine information across groups. So recognizing that role, we know that healthcare providers can really play a key part of sharing information that can address people's questions and concerns. Recognizing that role, we here at KFF, in partnership with the Black Coalition Against COVID and Dr. Rhea Boyd, have developed a new public information campaign that features W. Kamau Bell. It is designed really to dispel misinformation and provide accessible facts about COVID-19 vaccines through an open and honest conversation with Black healthcare workers. It includes a living library of over 50 FAQ videos that cover an array of vaccine-related topics, which will be continually added to over time. All of these videos are open source and available to use to support your own work, and I think we have a quick clip from the video to share with you now so you can get a sense of what those look like. So if you can roll that video, please.
Hello, Black America. There's good news out there. There's a COVID-19 vaccine. Yay! But the bad news is, as Black folks, it's hard to trust what's going on. So what do? Well, we turn to people we can trust. Black doctors and Black nurses. Okay, first question.
Can we try again with the audio, or is that just not going to work? Oh, okay. I see that the sound was on for the audience. Thank you. So hopefully that gives you a little flavor of those videos. We've had a great response for them so far. I've even heard some real world stories of doctors showing those to patients who initially expressed some concerns or questions about the vaccine. And then after seeing a video that addressed their specific concerns, they then felt comfortable getting the vaccine themselves. So again, all that information is accessible through our website and open source available to support your work. Beyond public information campaigns, we also are seeing a growing number of initiatives to address access and information barriers. Some of those are being implemented at the state level. Some examples of that work include making more vaccine doses available and locating more clinics directly in harder hit and underserved communities, as well as then prioritizing vaccine appointments or eligibility for people living in those areas. So we're learning that simply putting the clinic in that neighborhood is not enough, because then we're hearing stories of people coming in from other areas and taking up all the appointment slots in those locations. So really this combination of making the clinic readily accessible in the location that you're trying to reach, and then prioritizing or reserving vaccine appointments for people living in that community. We're hearing about new sign-up options being provided for people who don't have internet access. So, for example, phone sign-ups, also some walk-up and in-person sign-up options. And a lot of that work is happening when vaccination efforts are being led by community-based organizations and health centers that already have trusted relationships with these communities and who understand their preferences and the barriers they may face to vaccinations. We're also seeing more targeted outreach and communications campaigns that, again, are tailored to meet the specific questions and concerns that people may have. And then there's also the hard work and importance of collecting, reporting, and utilizing data to really have a complete picture of who is and who is not getting vaccinated, which can then be used to help direct resources to address where gaps are identified. And so we have seen more data become available, but there is still more work that needs to be done to really have a complete picture of who is and who is not getting vaccinated. So I just want to conclude today by emphasizing a few points. First is that equity in vaccinations is going to be key for really mitigating the disproportionate impacts that the pandemic has had on people of color and for preventing against even further widening of health disparities going forward into the future. Moreover, we know that reaching high vaccination rates across individuals and communities is going to be key for achieving broad population level immunity and protection through the vaccine. Achieving equity is really going to require deliberate, intentional actions that address those underlying structural inequities, and supporting and building on existing community resources who already have trusted relationships with communities is one key place we can start. And with that, I'll end.
Thank you very much, Ms. Ortega. This has been really a very useful and eye-opening presentation. I think that most people have figured out that they can submit questions by typing them into the Q&A. We've already had a number of them, so I'm going to start just by trying to summarize several questions into one. And I do have questions for each of the panelists, but since you're just up, maybe I could ask you, I think that you've rightly described that, in fact, vaccine hesitancy for many people of color really isn't an issue simply of them being hesitant, but it's actually the many systemic racial inequities and disparities that exist that make it hard for people, even if they are interested. And so my question for you is that, given that often the best approaches come through the community themselves, trusted leaders, pastors, their communities, the tribal leaders, how then is it best to integrate, because there's so many different communities, an effort that truly will reach out, that by necessity is going to probably have to involve the government, against which people don't always have enough confidence. And so that's part of the question. But the other question is, what can we all do to help? I mean, aside from donating money, for example, to certain efforts, is there anything that we as individual healthcare workers can do to participate in this?
Well, I think what we are seeing is that there are a number of efforts underway to learn from and build on the strengths that are already existing in the communities in terms of community-based organizations and community health centers that already have trusted relationships with individuals. So we're seeing this some at the state level with some states offering grants or going into partnerships with community-based organizations to design vaccination efforts and clinics. At the federal level, we are seeing that some additional vaccine doses now being directly allocated to community health centers, separate from the allocations that are going through states. They also just this week announced a new grant opportunity that would support local community-based organizations in advancing outreach and communications and assisting with the vaccination efforts. So I think there is work underway to build up and support and learn from and allow those communities to lead. In terms of healthcare providers and their role, I think you've heard consistently across our speakers just what a key trusted source of information you are for your patients. And so I think, as others have noted, really taking the time to listen and understand what people's concerns are, but also some of the barriers that they may face, and addressing those specific concerns and questions, I think, can go a long way.
Thank you very much. Dr. Brown, if I could ask you a question that's kind of two-part, again, combining some questions, is that you spoke a lot about how many people, their big link of trust is with their primary health provider. And yet there's a couple of problems. One is that most people, in fact, are getting immunizations, or most of the vaccines are being offered through mass inoculation sites, whether it's a pharmacy or whether it's Dodger Stadium. And so people, in fact, aren't interacting with their healthcare workers. And secondly, in fact, a lot of the concerns or mistrust about vaccines are the healthcare workers themselves. And so can you offer suggestions for first of all, should physicians be proactive about maybe sending letters or emails that explain the vaccines to their patients? And how do you then reach out to your colleagues to help explain issues so that they can get the information to overcome their concerns?
A great question. And I was reading the questions in the chat. You answered it perfectly. Sending out via the patient portal, here's where I want you to go to get your vaccine. I know that's what we did here in Chicago. Part of the reason, somebody in the chat said, if the PCP is so trusted, the personal physician, why aren't they giving it? Well, it's a logistics issue because of the refrigeration right now, and that's going to be overcome with the J&J, which does not have those restrictions. You know, hospitals in the rural areas, doctors' offices don't have that kind of refrigeration. So sending out, you're telling them where to go is almost as good as providing it yourself. Somebody asked in the chat, where did you get the button? I bought these on Amazon. I bought about 15 now. That everybody I know who gets one, I said, if you promise to wear this, I'm going to give you one. And they say, I will wear it proudly. I went to my dentist for the first time in a year. He's pro-vaccine. He's going to see a lot of people. He was complaining that his dental hygienists don't want to get the vaccine. And I gave him a button. So you are trusted. And somebody also mentioned the discord between race, and that trust with a personal physician. Not I hate to use the word trumps, but people still trust their personal physician if they have a long-term relationship with them.
Thank you. I think that's very helpful. So I actually have a question now for Heidi, for Dr. Larson. For example, the mRNA vaccines, actually the very first publication on them, and I know because this is an area I'm involved in looking at a lot, came out in 1990. So in fact, this is not some sort of just recently developed technology. It's taken 30 years to bring it to this point of fruition. But this is the sort of information that I think even people who are physicians, healthcare workers, don't always know. They just think of terms like Operation Warp Speed, and they think this was something that was done very quickly. What do you think may be the best way of educating healthcare workers as well as the general public about what really has gone into this matter, is it governments? Is it healthcare organizations? And also because of the concerns about the fact that these have been emergency use authorizations rather than full licensure. So if you could address how you think and who's the best organization or group of people to be able to address these concerns, both for healthcare workers and for the general public.
Yeah, I think that actually one of our failings as a scientific and medical community, public health community, has been to let the headlines grab it's so fast, it's warp speed, and really run with that. And we haven't spoken up on why they're so fast. There's been almost nothing about it. I try to raise it in any interview I do to explain, the reason it's fast is because we had new technologies. We also had a funding mechanism that allowed, and that was because of Ebola. We got CEPI, the Coalition for Epidemic Preparedness. There was money ready to leap into these trials. We, did parallel processes instead of linear, one after the other. Most of the public didn't have a clue that vaccines normally take 10 to 15 years before now. And they started to read in the headlines about how fast all this is. And the scientists themselves were saying, we're going to be first, giving a feeling of a race. So I think that, I think we should look at our own communication. And I think to your question about who should be speaking up, I think all of us should be speaking up. And every opportunity we have when somebody says this was all too fast, we can say, well, actually, you're right. It was faster than usual, but let me tell you why. And when we did the parallel processes that we would have done one after another, safety was not compromised. Pieces of this process have been shortened because of the wonders of new technology. And by the way, this RNA method is the first time it's used with vaccines, but as an approach, it has over a decade of research behind it. So I would use opportunities along the way to bring in that understanding, is what my view would be.
Thank you very much. That's very helpful. Dr. Gaissmaier, and by the way, for the audience, we've been given permission. We're going to keep this open for a few more minutes because there are just so many questions. So, so I'm trying to compress some questions together. Dr. Gaissmaier, my question for you relates to, you've given us some very good suggestions about how to approach people and what is memorable and what do people take away from things. I'm wondering, do you think there's any role as well when we try to explain about these vaccines, for example, to educate people about how to assess information they are given and not to pass on false information? Because what I've noticed is a lot of times people send around statements that claim to be from an expert or claim to state it's from the CDC, and in fact the information's not correct. So should we also be trying to educate people about how to deal with social media sorts of information, or even for regular media that may be incorrect?
Absolutely. So this is kind of a meta skill, digital literacy, health literacy, digital health literacy, that I think is extremely relevant nowadays. And it almost plays no part in school education, for instance, right? It starts with the teaching of mathematics, which is very much about the mathematics of certainty, not the mathematics of uncertainty. The latter are way more important, I would guess. And then also how to actually control the digital sphere rather than be controlled by it, how to detect good information, distinguish it from bad information, and that not everything that's written in a book needs to be true or something like that. Yeah, I think this would actually be extremely important, as we've seen with some of the conspiracy theories. They pretend to be scientific, And it's not so easy for people to detect that they are not. So they need to learn about trustworthy sources. They need to learn about what pieces of information make it more credible, and how credible information looks like compared to not so credible information, and so forth. And also know that there's web pages who check facts and help them identify good information. And I think also artificial intelligence is used by some of the big data companies to flag messages that are dubious to some people. And so I think this will also help. Yeah.
Well, thank you very much. I would just like to actually close with a couple of comments myself to address some of the questions, because it's a little more efficient if one person can answer them all. I would just like to say that I always think that being open and questioning of information is always really important. And so what's important is what Dr. Gaissmaier just said, is to check the validity and the unbiased nature of the information that you're looking at. There have been a number of questions that we received about particular medical conditions such as autoimmunity or people on specific medications. And as always, people need to consult, of course, their own healthcare workers, their own physician about that. But in general, what we should all remember is that usually the side effects that people have seen with these vaccines are very short-lived. And that's because it's the immune response responding to the vaccine. And so, in fact, people who have many diseases, whether it's cancer or autoimmunity, in fact, may be more susceptible to having a severe illness, not that the vaccine will cause them more illnesses, but that COVID itself will be more serious in them. And so one of the key things to always remember is everything is a risk-benefit ratio. And so depending on the state of the pandemic and depending on somebody's underlying health and their comorbidities, it's very clear that the risk from the disease is very great, whereas the side effects that have been looked at so far are really pretty much short-term effects. And there are very many post-licensure, post-authorization mechanisms where the CDC, for example, is collecting all reports of side effects and of adverse events that happen to people, and then following up on them so that we can make sure that we have a full safety information on them. So unfortunately, we're out of time, but if you enjoyed this program, I would like to encourage you that to see more follow-up on MJH does produce a number of other programs related about the COVID, and they are on demand. And so you can actually look at them if you just put in your address, follow the address on the screen. And if you're interested in learning more about the International Society for Vaccines, we're a scientific society. And what we do is to try to help both the members and other scientists present their work so that we can have a more global advancement of the development of new and beneficial vaccines. So we actually have our own conference series that's been going on. This is a number of them where we give updates on all the development of various vaccines, both COVID as well as influenza, for example. And so please just visit us online at isvcongress.com as well as isvonline.org. So I'd just like to thank again all of my co-organizers, Dr. Doolin and Dr. Klavinskis, as well as all of our speakers today for their tremendously informative and useful information. And thank you also for the wonderful questions that we received from the audience. Your thoughtful questions were really appreciated. I'm just sorry we didn't have time to go all of these, but we will be ending the program here with a link to a survey where you can give feedback to help us make better ones or additional ones as we go along. And also, as you know, you will be able to access this presentation again, so that if you'd like to go over, because I know many of the points were just so useful going forward as we deal with our patients and our friends and our own personal questions about ISV. So thank you very much to MJH Life Sciences and to ISV for supporting this and making this possible. Thank you. And thanks again to our panelists. Bye-bye.